So when we go to the first session by Dr. Nimita, she's working as a consultant in Comtrest. Over to you, Nimita.
Good afternoon. Uh, I would like to thank KSOS and Bindu Madam for this opportunity. So I'll be talking on overview of MIGS, why and in who. So there are various treatment modalities in glaucoma. One is the drops, other is the surgery. So the drops as such, SLT and light trial, it is shown that SLT group did better than latanoprost group, and it required less intervention for glaucoma surgery. So in this we understand that early intervention is better, and also it will reduce the and also for non-compliant patients, and whether the drops are harmful or not, that is also a big major concern. Then there is the surgery. This surgery basically glaucoma surgery requires more post-operative care and longer visual rehabilitation. It has also complications also. MIGS, that is the minimally invasive glaucoma surgery, it acts as a bridge between the medication and the more invasive surgical options. So, a MIGS is an ab interno approach with reduced tissue manipulation. It is conjunctiva sparing and with least modest efficacy and extremely high safety profile with rapid recovery. So, usually the aqueous it drains through the trabecular or through the uvoscleral outflow, and MIGS basically it acts by increasing the trabecular outflow, or by increasing the outflow through the suprachoroidal space or through the subconjunctival space, or by directly acting on the ciliary body. So in the trabecular outflow, there are stents, and also the ones which will dilate the canal. The stents are the iStent and the Hydrus. The ones which excise or cleave is the trabectome, the GAT and the KDB, and the ones which dilate is the iTrack and the Omni. So the MIGS procedure basically it depends on the glaucoma type, the severity, the patient characteristics, and the desired IOP reduction. So in the IRS registry in USA, there has been shown that there is an increase in MIGS procedures, and also most commonly done in open angle, angle closure post PI, and also in normotension glaucoma. And up to 2018, the most commonly done procedure was the endocyclophotocoagulation and the iStent. And also when we look into the quality of life, it has got equivalent quality of when compared to cataract surgery, and also the IOP reduction is more when compared with the cataract surgery, but the major disadvantage is the cost. So this is a retrospective study which is done for a 6 months. This one it shows that the phaco with goniotomy, that is with the KDB, has more IOP lowering efficacy than the iStent, and the major complication is the IOP spike. When the long-term results were compared, that is, it showed that KDB has a 28% reduction from the baseline, and also reduced the medication of 30.8% from the baseline. Even GAT procedures, when done in severe advanced glaucoma patients, there was an IOP lowering and also reduction of medication seen. So, so I would like to tell that MIGS overall the reduction is about 25 to 30% from the baseline. 1 to 2 AGM it will reduce from the baseline, and the success rate is more than 50%. With complications like transient hyphema and IOP spike. But the contraindications are uncontrolled uveitic glaucoma, neovascular glaucoma, acute angle closure glaucoma, if, and also in iStent and trabeculectomy, it is the peripheral anterior synechiae. If it is there, it is contraindicated. And CyPass and iStent supra, there can be history of uveitis and scleritis. Thus, to conclude, we have to understand the devices and the procedures so that we can enhance the patient care, and I can ultimately strive to preserve vision in glaucoma patients. Thank you.
Thank you, Dr. Nimita.